This is what we call your crash cart. So this has, this is your defibrillator. So if you're kind of shock someone back, you kind of put them on, here's your paddle. So you just kind of, charge it up. This is all your kind of crash cart medicines if someone kind of, needs resuscitation. So their heart stops, they're starting to stop breathing. You have all your different medications and airway stuff that we use to kind of put them on a ventilator to breathe for them if someone stops breathing. Don, how are you, buddy? And then we even have, this is called our interosseous line. So if you have to get IV access, but someone who's really sick, it's sometimes hard to get IVs. You can quickly drill a needle into their bone marrow. So you can do it on their humeral head or tibia or the femur, and you can just infuse fluids, medications, blood all the way through that, and it goes into your system through your bone marrow, which is kind of a cool thing.
Very cool.
We have just the regular cardiac monitor to see what the electrical rhythm of their heart is, blood pressure, oxygen, all that kind of stuff. This is more my physician stuff. The nurses typically do that when we just say, hey, I need, stat, epi, all the other stuff you may see on TV, or shock, do that stuff. They're doing that. This is kind of my stuff that I would do. So if someone stops breathing or they can't breathe, I have a couple of different devices that you can kind of, breathe for them. One of which is this cool little video laryngoscopy. So it's a little fiber optic, so you can see. You look in your mouth, and so you can see.
You just slide it down the throat.
You can see on there, so you can see into his throat. So you kind of go in there, Molly. You see. So you have to kind of know where to go to get into their trachea versus, and then you insert this little tube right here. You want to get it into the trachea. You can't go into your esophagus. If you go into your esophagus down your stomach and you start to breathe through that, well, guess what? They die because you're just breathing into their stomach and not into their lungs, so they don't get any oxygen to their brain or their heart. And these are the different types of tubes that you put in to breathe for them. And then you ventilate with either this big bag, what's called an ambu bag. You're just kind of breathing for them, or you put them on a ventilator. That's a machine that does that. It has a little cuff that you open up to kind of secure it in there with a little balloon. Then we have a different type of device. If you can put this in there, if you can't for some reason pass that tube where you can see with the right through your vocal cords where you go through. It looks kind of like a V. You put this in, and it kind of just covers the back of their throat, and you breathe that way, and it passively tries to get air into their lungs versus their stomach. Not nearly as good, but if you have to try to save someone's life. This is even more aggressive. This is where you've ever heard of the ballpoint pin you put in the neck. So if for some reason their face or something is so smashed in that you can't get and they can't breathe, and you can't do this or this, you have to do what's called a surgical airway. So you actually feel for the little cricothyroid cartilage right here. You cut open the skin, you puncture through there, and I can put this through there and put a little tube in right here that goes straight into their trachea to kind of breathe for them that way. Again, all kind of life-saving things. These are thoracostomy tubes, so if someone has a severe collapse of their lung or bleeding into their chest from a stab wound, a gunshot, a trauma like fall from a motorcycle or bike, you have to sometimes, the pressure in your chest can build with blood or fluid or air escape out of your lung, and it can kind of compress your heart. You can die from that, so you have to quickly put a big tube in their chest to kind of either get the fluid out or really just kind of let their lung expand back so that you can actually put one of these tubes in to ventilate for them. These are major, big, somebody who really needs a lot of resuscitation, near death, and a little small IV in your arm is not good enough. I have to put a big IV up into their neck, into the major vessels of their chest or their neck, and I have an ultrasound that guides that, and we put that in to kind of give them blood or things.
So it gets more intense as you go down the
different stuff. This is a spinal puncture, spinal tap, lumbar puncture if you have to check for someone who's got severe infection or bleeding into their brain or around their brain. And then these are, again, if you collapse your lung, I have a nice little needle thing to kind of put in there to kind of open them up. Then we have a bunch of other just like little equipment thing to, like if you cut off the tip of your finger and the bone's sticking out, I have a bone rounder. I have to kind of cut it down to get the skin back over it. Got all kinds of fun little stuff. this is like a fun one. So if little kids put little stuff in their nose or ears or whatever, this is called a mosquito or alligator forceps. It really kind of looks like an alligator. So you can go in there and pull out little beads and little, I pulled out all kinds of like beads and food and all kinds of stuff out of people's noses and ears and stuff. Cockroaches out of ears.
Oh, God.
Wonderful.
Cockroaches.
Yeah, seriously, amazing amount of how many bugs get in people's ears. But this is to cut off a ring on your finger. If all of a sudden you smash your finger and it swells up immensely, then it's like a tourniquet on there. So I can put this on there and cut off someone's ring. All kinds of little fun stuff. So that's all of my kind of big stuff there. I think we have like a delivery kit if someone's going to deliver a baby real quick. I just did this at the hospital not too long ago. They delivered kind of in the car really outside. We just quickly grabbed them and they just had delivered and just brought them in and clamped the cord and all that stuff. This is my pediatric stuff. So again, I have it over there too, but like if you have to use a little tape to see how big, if a baby comes in who's, you need to resuscitate, they stop breathing or their heart stopped. Depending on their size, everything's kind of separated out and organized for you on certain weight, like 5 kilos, 7 kilos, 10 kilos, 12 kilos. You just kind of go up in size until, and so that you have all the right sizes for tubes, IVs, little resuscitation devices, just because you want to get, obviously you have to give the right dose, right size for these kind of kids versus, an adult.
Mm-hmm.
And it's much more critical. Otherwise, if you gave an adult dose, it could be 10 times the amount that you're supposed to give or something, which is not good.
Okay, Dr. Aldred, what is your profession?
I'm an emergency physician.
All right. What inspired you to follow this career path?
So when I was a little kid, I wanted to be a physician. I think my grandma was really sick when I was like in second grade, I believe, and so I couldn't figure out why they couldn't get her better. So I figured I wanted to be a doctor from then on. So then I went through obviously college and medical school, and then when you go through medical school, you rotate through different specialties. You'll do 3 months of internal medicine or surgery, pediatrics, and you get a chance to kind of see which specialties you really like. And I really like the surgical kind of specialties, which you get to do procedures and kind of like acutely change someone, so that if you have acute appendicitis, you can fix them from that, or you have a gallbladder attack where you need to kind of take the gallbladder out. That was exciting, but I didn't love being in the operating room, so I kind of heard about emergency medicine, and I rotated through emergency medicine, and it was just like right with my personality. You got to do lots of fun surgical procedures, like I was showing you with the equipment that we have here, and it really makes a difference. Someone's in dire need, either very ill or potentially near death, and you can turn them around. But even as simple as someone who has a fractured arm from playing soccer, and you need to kind of set the bone and get them splinted and casted, is what you guys would think about. That's just exciting because they're so much better after you're done with them in a very short period of time.
Cool. So that since second grade, this is what you wanted to do.
Yes, correct.
Okay. All right. Did you ever question becoming a physician along the way?
I probably didn't question becoming a physician, but I questioned what type of physician. Initially, I thought I probably would be a pediatrician just because it seemed like it was kind of nice to help kids out. But then you start to rotate through these different specialties, and almost everything I could be that. That would be great. I could be a surgeon. And then my brother became an internist, which is an internal medicine physician. Your typical kind of brainiac doctor that just needs to know about everything and treat all kinds of illnesses from any adult illness all the way through death. But some of those things just were a little bit less exciting for me, and so I never did question, I think, becoming a physician, but definitely you'll even in your plans for your healthcare professions, you'll question what type of healthcare profession you want to do.
What ethical issues have you faced as a physician?
Boy, that's a tough one. So ethical question, you face ethical things every day. people have to decide on, do they want some treatment, especially end of life is probably the most common. Someone's really ill with cancer, and there's a lot of things you can do potentially. Should we do those things? Does the patient want those things to happen to the family? Maybe the patient can't make a decision on their own, so you have to rely on family or the next of kin to make some really tough life and death decisions. So those are probably the hardest things. Is that end of life care, whether to be very aggressive and continue to try to do things, although sometimes it becomes to the point where you can't save someone's life and you just want to make it better quality of life, so that sometimes you wouldn't do all the invasive procedures. You want to make them feel comfortable, out of pain and out of distress.
What is the weirdest or craziest thing that you've treated in the ER?
Wow, that's tough. I have lots of really terrible stories, gory stories. The weirdest, craziest. I think Molly may have prepped you on one of these. Probably the weirdest, most bizarre, if I can tell you on this little video, I'm not sure, was a young lady who had multiple personality disorder. So she came in as a sexual assault. So she was sexually assaulted, but the personality that was sexually assaulted was not who was there with her at the time. So it was very difficult to get any story because that personality wasn't there. Her friends, though, had corroborated a little bit of the story. Unfortunately, it seemed like there was probably some drugs or alcohol involved, so it was hard to kind of make sure that the story was correct from any of these folks that were there, and these are young kids your age. So we ended up, I have to do a full examination to see if there's any signs of sexual assault. Well, as I'm doing a vaginal examination, there's a piece of metal in the girl's vagina, and quickly did some testing to see, and it was in the shape of a star on an x-ray film. So I had the gynecologist and myself ended up removing this, and kind of a small surgical procedure in the ER. And then after we removed the star, there was a dead snake also in her vagina. So everyone was worried, is the snake poisonous or not? It really wasn't. That wasn't a big deal. But it was, then we found out later there was some kind of weird seance that was going on, and that was part of the seance ritual. And again, the story was really hard to corroborate just because of the different personality that was there, but it was a very interesting situation.
Well, interesting.
Okay, is this number 2? All right, so age. Well, so this is very stressful. I bet. And is it worth it to do that to you, even though it does put a lot of stress onto your, I guess, mental health? So
yeah, being a physician is unfortunately one of the more stressful positions. The rate of suicide, substance abuse, and such in physicians is higher than the general population. Just because I think it's very hard to cope. So you have to have things that you know how to cope with stress, and try to do your best. Unfortunately, you try as physicians to be 100% correct 100% of the time. Very difficult to do. Everyone knows that you can't do that. So I employ things what I call high reliability techniques. Things you really want to try to make the process of how you do stuff reliable and accurate virtually every time. So do the same thing almost exactly the same way every time in different situations. So that decreases your amount of stress that you have because you know you're doing the best you can every time. Sometimes things still go bad and you just have to deal with it, and it can be very difficult, but you have to have those coping skills. The other things you have to do is you have to recharge your battery at home. So do things outside of your medical profession. Like we do traveling. We just like to travel, like to go out to dinner, things like that. Those are things that spend time with your family or loved ones kind of helps you kind of mitigate all that stress.
Okay, now we're going to start talking about your undergrad experience. Where did you go for your undergraduate degree?
I went to the University of Illinois at Champaign-Urbana. Go Lagunas.
Yeah. So how did you choose your undergrad college?
Well, that was one of the closest not big university to my house. There was an in-state, out-of-state tuition significant difference when I was younger, so that was the school that was the best school I could go to. You know, that still had it was probably the cheapest at that time to go to for a great school. Actually, very similar to University of Texas. I think it's the best school in Texas, especially for the price, and that's the same thing with Illinois. Very similar school actually to the University of Texas on rankings and such.
Were you prepared for medical school?
I'd say so. I think medical school is your first year of medical school, especially is a whole lot of science and classes that you've already had, but at a lot more aggressive pace and significant caseload. Instead of having 5 classes in the semester, I think we had like 13 or so courses, and instead of doing it in one, in like a 1 year, you would do that in about a semester's time. So it just increases the speed of what you have to learn and what you need to know by about 4 times what you would do in college. And that's more the didactic portion of that school. And then you are starting to do labs, and then starting to get entry into physical diagnosis and patient interactions. That's where it gets really fun, and I think you can't really be prepared for that as much unless you've had some experience in healthcare. There was other students that had been like assistants, nurses even, and paramedics. So that experience is great to help you into medical school. But just learning how to diagnose people and taking all that responsibility to make those decisions is really what medical school is about. And that's something you have to learn along the way. So it's not really easy to prepare for that.
What was your major in college?
I was at honors biology.
What were the most interesting clubs or organizations that you were involved in your undergrad?
That's probably the most, which I was mostly involved with, my fraternity, Delta Tau Delta. And just because it was a great group of people, we had, we were actually, I think, very socially responsible, and then academically responsible, but had a lot of fun in intramural sports and all kinds of fun social activities, but then also just a lot of other professional activities. You can get involved with other campus activities and like student council on campus, and a fraternity council. We had lots of volunteer stuff that we did with what's the name of Special Olympics, I'm sorry, I blanked on that one, Special Olympics and that kind of stuff. So very, very good experience for college and get you prepared for life.
So, did your major in your undergrad, did that prepare you for medical school and for the MCAT?
I would say pretty good on like the chemistry and biology of the MCAT, but not as much so on some of the other things. So I think you really need to learn, and it may be different nowadays, but it's probably good. I didn't take any prep course or anything like that. So you really probably should get yourself prepared by doing some kind of prep courses for the MCAT. And I believe it's changed where you do have some essay portions and things like that now. So you will be prepared likely, but it's a difficult test, and you probably should do some preparatory work outside of college.
Okay, so overall, how did your undergrad experience help you in your profession?
I'd say probably the most thing is just teaches you how to manage your time, make decisions, be responsible for yourself, and learn the material you need to learn. And then, I believe that the leadership activities that I took on during college and my undergraduate helped me significantly, just to be able to have those kind of responsibilities as you become a physician. Physicians, the amount of responsibility you have to take is just immense, because you really make the decisions for everybody, including the patient, their family, all the other people that work with you as far as the nurses and technicians and other folks. So you are the responsible person to make all those decisions. That's the most difficult thing, is just to take all that weight on yourself.
Do you have any advice for freshman students like us?
So just kind of obviously work hard, but learn. It's not all in your classes where you kind of are going to be prepared for medical school and your career as a physician. It's in activities, especially if you can get into some leadership activities, other things where you actually learn above and beyond what you're learning in your classes. Classroom work is a lot to teach you how to learn and so that when you really get to important things that are more important for your profession, you can learn those and quickly learn those and be responsible to learn them on your own rather than having someone else have to be responsible for that information. So just kind of make sure you branch out, get into some activities, and try to take on some leadership roles, be well-rounded, and then obviously do well in your classes.
With all those activities, would you have any advice on how to balance it or manage it in our schedule and throughout what we do?
I think the best thing is to try not to overload yourself with classes for a semester. I think a lot of people luckily come in with some credits, which is kind of nice nowadays. They didn't have AP classes when I was in high school, really. Too bad. But so you really want to, you have enough time in college. There's lots and lots of free time, right? So just try to balance out, you can put just like another class instead of having that amount of work, that 10 hours a week or so that you have to put in for a class, do towards some volunteer thing or some other activity. So just think of it as like another class and then just try to do that amount. That would probably be smart.
Okay, so our last question for you today. This is my favorite. What are your thoughts on medical-related shows such as Grey's Anatomy?
Wow, it's very sensationalized. Back when I was in my training, I was already in residence for emergency medicine, and that's when the first ER show came out. And they actually filmed at my hospital in Chicago while I was in training. So on the show, a perfect example is that they would show resuscitations like I was talking to you about before. Someone stopped they have a cardiopulmonary arrest, and 90% of the time plus the person was resuscitated alive and talking at the end of the show, and seemed normal again. So that is so far from the real facts. It's about 10% of the time actually someone really is able to be resuscitated from an acute arrest. It depends on the type, obviously, to become a normal in their pre-arrest state even in a short period of time is really unrealistic. So those shows are unrealistic. They give unrealistic expectations, but they do use some real medical things. And they actually many times ask questions to medical professionals on neat stories, interesting stories to have on the show. It's just unfortunately unrealistic as far as what really happens with medicine.
All right, thank you so much.
Mm-hmm.
Thanks,